Great. So I think we are live now. Am I audible, visible to everyone? I think yes. So very good evening to dear students. I hope you have given your test yesterday and I hope it went well because I'm sure that you are preparing very hard for your exams as INICET is just few days away. And you must be in a very high spirit. You have a lot of time before your NEET PG counseling also. So this is one way, guys, we can, crack this exam because we are now mentally free. So one should always give this INICET exam. So friends, I hope ophthalmology went well and you're enjoying this INICET 2024 series with us at DocTutorials. So without wasting time, let's jump on to our first question. So it says that a 40-year-old female present with complaints of diplopia of sudden onset with headache, nausea. Also, she complains of sudden loss of vision, which she regains in some time. She has no history of diabetes and hypertension. And when we examined, the vision was little less with the early cataract. Retina was normal. Visual field was also normal. Pupil shows normal reflex on both sides. So what is your provisional diagnosis? So first, I would like to ask you, what is the diagnosis? Anyone who can answer the question? Anyone? So friends, this is an integrated question. I would say it is an integrated question with psychiatry because here the correct answer is that she is a maligner. Okay. Now, guys, what clues we have? Now, if we go through the complaints, it seems that she has little diplopia, there is a headache, there is a nausea. She says that there is a sudden loss of vision which she regains in some time. Maybe a amaurosis fugax, but there is no systemic history which is suggestive of that. Now, when she came to me for an ocular examination, for a checkup, I found that almost everything was okay. And also retina examination is normal. Visual field examination is also normal. And when I check the pupils are also normal. So friends, what could that be? You know, if we think about cortical blindness, then in cortical blindness, you know, there may be a confusion like with pupil are normal and there must be a loss of vision, but that loss of vision will be sustained. You know, this loss of vision will be sustained in case of cortical blindness. But here, what have we seen? We have seen that she is giving us a very different kind of history. So, you know, guys, why the answer is not a retrobulbar neuritis, which is asked to us so many times, you know. So this is not retrobulbar neuritis because in this case, the pupillary reflex should be abnormal. We should have a RAPD here, isn't it? If RAPD is not mentioned, retina is normal, then you can think about something else. But if it says patient is complaining of decrease in vision, retina is normal, but pupils are also abnormal, then you can think about retrobulbar neuritis. Third nerve palsy is absolutely out, isn't it, guys? Third nerve palsy is absolutely out. And I have told you why it is not cortical blindness, because when I examined, the vision came up to be normal. Right, everyone? So this is purely a case of a maligner. So I can say, if we ask you what is the further step, we can say the further step is we can go for a psychiatric counseling. We can go for a VEP also to make a diagnosis. But here, if they are asking you about a clinical diagnosis without even a VEP, then you can consider the patient is a maligner or patient has a hysteria probably. So friends, I would again like to say, you should know that how to distinguish between a retrobulbar neuritis, a papilledema, and you should also know how to differentiate cortical blindness for a maligner. So we have four things here. We should know how to distinguish one with other. All right, friends. So this comes to be a very, very important question. Now, guys, I would like to tell you something more about this light reflex, this pupillary pathway. So I'm sure you know that pupillary pathway is different from your visual pathway. Like in visual pathway, we have that LGB, but here we don't have LGB. We have a pretectal nucleus. Internuncial neurons go through pretectal nucleus to the Edinger-Westphal nucleus. Then the preganglionic fibers come and then they go to the ciliary ganglion. From ciliary ganglion, you have third nerve. And then finally, the short posterior ciliary nerves are innervating what? They are innervating the sphincter pupillae muscle. All right, friends. So please remember, this is also a very, very important topic. You should know your pupillary pathway, right? Pupillary pathway is important for us nowadays. Okay. Now, third nerve palsy, we have kept this also as a differential. The options also ask us third nerve palsy. So I would say this doesn't present like that. In a nuclear third nerve palsy, we might have a bilateral ptosis, but here when we have a left third nerve palsy, as you can see, there is a ptosis. That's why examiner is lifting up the lid. You can see the eye is out. You can see the eye is down. So characteristically, we have a down and out eye. And once you see carefully the pupil is also dilated. Okay. Now my question to you, is there any condition where you don't have pupillary involvement in third nerve palsy? Anyone who could answer? Is there any condition where pupillary sparing third nerve palsy is seen? So I would say yes, there is a condition. And what is it? It is what has happened to my screen? Just a minute, I have. Yeah. So yes, diabetes and hypertension, I would say the medical causes of third nerve palsy, where we don't have aneurysm or any surgical compression. In those conditions, we will have a pupillary sparing third nerve palsy. So you should remember this question as well. All right. Now, what does the second question say? So guys, in INICET, I am expecting one question again from your squint examination. Okay, you may have one question from either Maddox rod test or maybe a Hirschberg test or a cover and uncover test, right? As we are expecting a list of questions from your examination of squint and the test related to the squint. So this is one more question which I'm expecting. So I'll give you an overview of the Maddox rod test, right? Because I am getting so many queries. Students are asking me, how ma'am, how to do this Maddox rod test? So let us have this brief discussion about this Maddox rod test also. So friends, first of all, I'll tell you, examine this. What is it? Can you identify? I'll say this is a Maddox rod which is having a series of red colored cylinders packed together. Okay. Now remember, what is the property of a cylinder? The property of a cylinder is that it makes image perpendicular to its axis. Okay, you have to remember this statement. If you forget this statement, then everything will be wrong, right? So what is the property of this Maddox rod? What is the property of the cylinder? So here, the property is that once you see a source of yellow light, through this Maddox rod, which are oriented horizontally. If they are oriented horizontally, and if I see a torch light, the yellow color torch light, I will see this torch light as a vertical red line. Understood the property? So can I say, if I put Maddox rod only in front of right eye and I see a yellow torch, okay, and I have a visual target as a yellow torch. So if I am a normal person, if I am orthophoric, what do you mean by orthophoric? Ortho means straight eyes. If I have no squint, no phorias, no tropia, then what will I say? I'll say that from my left eye, I see a yellow light. From the right eye, I see a vertical red line. And because I have no phorias, no tropia, so I'm able to superimpose these two with each other. Are you able to understand? I will be able to superimpose this yellow light with a vertical red line. That means I have orthophoria. Now, friends, what is the property of this Maddox rod? The property is that it is going to break the fusion. It's breaking the fusion. And now if it is breaking the fusion, that means it is going to make the phoria visible for us. Phoria will become a tropia. So how will phoria become a tropia? Once you break the fusion. This is the whole idea. Okay. Fusion is broken when both eyes get different stimulus. My left eye is getting a yellow light, but my right eye is getting a different stimulus. That's why the fusion is broken. Understood? Now, to interpret this, we should also have something. What is it? We should remember that crossed is crossed diplopia. I want to say crossed diplopia is seen in Exophoria. So first of all, we have to remember this concept. Once we remember this concept, we will be able to solve our question very, very easily. Very easily. That means what? Cross diplopia means I will see the image on my left hand side with my right eye. I will be able to see the image of the right side from my left eye. This is the meaning of cross diplopia. Now, if the person has an exophoria, what will he report to the doctor? He will say, ma'am, I am going to see a red vertical line on my left hand side. Left hand side. Okay, left hand side means what? That the right side forms the image on the left hand side. This means there is a cross diplopia. And what is the interpretation of this side? Patient will say, ma'am, I see red line here. I see a yellow light here. Okay, yellow light which is formed by left eye. Right eye sees the red line. That means there is a cross diplopia. So if the patient is reporting you this, that means the patient has exophoria. But if the patient is reporting you the other thing, that means there is a right eye sees a red line, vertical line, and the left eye sees a yellow light. That means there is a uncrossed diplopia, and uncrossed diplopia is seen in esophoria. So friends, please remember this Maddox rod test. It is very, very, very important for you all. Now, guys, please understand Maddox rod test is not for tropias. Okay, for tropias, we have Hirschberg test, we have prism bar cover test, we have cover test, but it is not for tropia. So I'm sure you know what is esotropia. Esotropia is inward deviation. Inward deviation. What is exotropia? This is your outward deviation of the eye. So please remember the cover test also. I'll give you an overview what is cover test. Remember the correct words. Cover test is not for diagnosing any tropia. It is just to confirm that there is a tropia. Because tropia is a clinical diagnosis. I can see there is a tropia. Okay, there is a manifest squint. So remember, in cover test, we are supposed to cover the apparently normal eye, the apparently straight eye. The moment you cover the apparently normal eye, the undeviated eye will move to the center and it is going to take up the fixation. So this is the main importance of doing the cover test. Okay, remember. Now, friends, something more about this. You should know what is secondary deviation and how to differentiate it from the primary deviation. Okay. So what is primary deviation? Anyone? Primary deviation. What is secondary deviation? So friends, you know there is a tropia. Okay. There is a tropia. Right eye is deviated outwards. There is a tropia. Okay. Now, if this is because of a paralytic squint, what will happen? Paralytic squints may you have secondary deviation more than what primary deviation. What do you mean by that? So we need to know what is primary, what is secondary deviation. So the deviation already of the squinted eye, this is called as a primary deviation. Just a minute, friends. Hello. Hello. Am I visible now, friends? Hello. All right. Okay, friends. So I was telling you that how to differentiate between a paralytic squint and a non-paralytic squint on the basis of primary and secondary deviation. Okay, so I'm expecting this question also in the coming INICET exam. So friends, what will happen? See, look at me. You have a patient who has a tropia. Okay, there is a tropia here. Now, the moment you cover this eye and whatever is the deviation of the deviated eye, this is called as primary deviation. Okay, this is your primary deviation. You measure the amount of deviation in terms of prism diopters or in degrees, right? Now, if you happen to measure the if you happen to cover the deviated eye and now you measure the deviation of the normal eye, this is called as secondary deviation. So in cases of non-paralytic squints, both of them are equal. The primary deviation will be always equal to the secondary deviation. But what will happen if you have a paralytic squint? So in paralytic squint, always the secondary deviation is more than the primary deviation. So you should know the secondary deviation. What is it? What is primary deviation? Okay. So this is one test which will tell you the secondary deviation and primary deviation. So again, guys, Maddox rod, uncover test, and this primary deviation and secondary deviation, they can ask you. Okay. So let us discuss the third question. The third question says that we have a 53-year-old man with type 2 diabetes, and when he comes for an annual review, I saw that there is a new vessel formation at the optic disc. Visual acuity is not affected. Blood pressures are almost normal. HbA1c is higher. So what is the most important intervention in this patient? So can I say, anyone, what is the answer? What is the answer, friends? The moment I see there is a PDR, there is a new vessel formation. This means that there is a PDR, there is a NVD, isn't it? There is a NVD. So whenever you have a NVD, you should do a laser. What type of laser? You have to do a pan-retinal photocoagulation, isn't it? You should do a pan-retinal photocoagulation. Uh-huh. Now is it visible? Okay, good to go now. My God, lot of trouble this way today. All right, all right. Chalo guys, so let us now begin with it. It's a lot of time now. Now again. Chalo, I hope you now understood, guys. This is your PDR. This question says that there is a PDR. So the moment I see PDR in a patient, we are not concerned about the vision. We are not concerned about the maculopathy. This is to be lasered. Okay, what type of laser has to be done? This laser will be a pan-retinal photocoagulation. Okay, so please remember the treatment of choice for PDR is always a PRP. Okay, this is the crux of the thing that you have to remember. Okay. Now, let us go quickly with this because diabetic retinopathy is another very, very important topic which they keep on asking us, right? So, friends, diabetic retinopathy is classified by ETDRS classification, ETDRS study. Okay, so we classify this in NPDR and PDR, you know it. Now, NPDR is further classified into mild, moderate, severe, very severe. You should remember this 4-to-1 rule also. This can be a question, okay? So, even if you have a very severe NPDR, this is not an indication of treatment unless until you have a maculopathy. So remember this question also. If you have a NPDR with your maculopathy, then only you need to treat. Otherwise, you need not to do anything. Okay. Remember, this is a question. Now, friends, if you have a PDR, any PDR, that PDR has to be treated. Okay. So you can have a picture question anytime. They can ask you a arrow here and what lesion is this? So I would say this is a flame-shaped hemorrhage, right? What is this? This one is a kind of cotton wool spot. This definitely is a cotton wool spot. This yellow one is a hard exudate. Okay. Now here, what is it? This is a cystoid macular edema. So the moment you have an NPDR, but you have a cystoid macular edema, this is definitely an indication of treatment. Okay, remember this question is also very, very important. So what are IRMAs? So IRMAs, are they suggesting you that there is a PDR? No, not at all. IRMAs is definitely just a pre-proliferative stage. IRMA is intraretinal microvascular abnormalities. So you have venous bleeding, you have IRMAs, but this is still NPDR. Remember, this is not a PDR. Students get confused looking at IRMAs. Okay, IRMAs are pre-proliferative, right? So if you have one IRMAs, don't think that this is a PDR. This is gonna be a NPDR only. Okay. Now again, another pictures, beautiful pictures of flame-shaped hemorrhage. You must remember, you can have anytime any picture question where you have to mark the lesion. What is it? You have to tell us. Okay. Now I'm sure everybody knows what is PDR. PDR is you have a front of new vessel anywhere at the disc or anywhere elsewhere. So this one is going to be NVD. This one is going to be NVE. The moment you have new vascular front, you will say that this is to be lasered. Irrespective of the status of macula, even if the macula is normal here, you need to do a complete pan-retinal photocoagulation. So that is what I want to impress on. Okay. Now, what is this injection? Anyone? What is this injection? So this injection is an intravitreal injection. Okay. We can give anti-VEGFs by this route. We can give antibiotics. We can give steroids also by these routes. Okay. So this is your intravitreal injection. Now let's move on to fourth question. So we have a young man who comes to OPD with sudden increase in floaters. This is a beautiful question, guys. Try to answer. There is a sudden increase in floaters. So he has been using glasses since a long time. And on examination, his vision is 6/6 with a high-powered glasses. In the retina, the tear is observed. So what is your provisional diagnosis and how will you manage the case? So anyone, if you can answer this question. It's a lovely question, guys. If you can try answering that. Many students consider that this is a case of RRD and probably will do laser. Some of you might have said that this is a RRD and we might have to do a pars plana vitrectomy. But I would say this is none of them. The correct answer here is that this is a retinal tear showing and we have to laser the tear. This is the correct answer, friends. Please remember there's a big difference between RRD and the tear. Remember, this is very, very important. If the patient has come to you with a sudden loss of vision, if there is a sudden loss of vision or there is a feeling of a curtain over the eye, then you can probably think upon RRD. But there is a big difference between RRD and presence of a tear. No, no, no. The answer is not no intervention required. No, you should laser it. Why I'm saying you have to laser it? Try to understand the patient's condition. So it says there is a usage of high powered glass. That means probably he has have a myopia since a long time. Now there is a sudden increase in floaters. There is a increase in floaters. So guys, if there is an increase in floaters, then definitely you have to intervene. See, even I can see floaters. Might be that floaters is a complaint to you also. But if there is a sudden increase in floaters or if there is a flash also, then definitely this is an indication of treatment. Please remember, suppose if one of the intervention says no, one of the options says no intervention required, I'll still say the best answer here will be you have to laser photocoagulate. That's what practically we are doing, guys, okay? In our clinical practice, if we have a myope who has developed a retinal tear, see, look, you can have a picture question also. They haven't asked you these kind of picture. This is a beautiful picture of a lattice degeneration where we have crisscross changes here and there is a tear lying nearby the degenerative area. So again, guys, this is important. I just want to say that the moment we see a tear and if there is an increase in complaint, if there is a sudden increase in floaters and flashes, you must laser, okay? So please remember that is how we do it. This may be an expected question. This is called as laser barrage, okay? Barrage means that we are sealing it. Which lasers are we using? We are either using a argon laser or we are using double frequency Nd:YAG. So either of these two. Okay, friends, please remember this may be a question. Now, again, there is no use of doing a PRP. PRP is mainly done to decrease the VEGF thing to kill the hypoxia. That's what is the role of PRP. We are not doing a pan-retinal photocoagulation and not even a pars plana vitrectomy. Understood, bache? Please remember. Now, guys, certainly you can have a picture question on RRD. They haven't asked you such a beautiful question on a horseshoe-shaped tear. Okay, so horseshoe-shaped tear again can be your very important picture question. All right, guys, another picture where we have a horseshoe-shaped tear. This is the area of retinal detachment. And I would say the feeling of curtain and floaters will be in the opposite quadrant. So please remember, the patients of RRD can have a feeling of curtain. This curtain will always be in the opposite quadrant of the RD. Okay. So if I say the RD retinal detachment is on the superior part, the curtain will be in the inferior part. So remember this way. Okay. Please remember it. Now let's move on to the fifth question. So what is correct about cataract surgery? Are we using methylene blue dye to stain the anterior capsule? Is it? No, guys, we are using a trypan blue dye to stain the anterior capsule. What is this IFS? Guys, I am again expecting an important question related to IFS. IFS can lead to a widely dilated pupil. Not at all. Rather, it leads to a progressive constriction of the pupil. What is IFS? Anyone? What is IFS? Important question, guys. So the next one, pseudo exfoliation can lead to subluxation during cataract surgery. And flax helps in nuclear emulsification. So guys, if you know about flax, then definitely this is the absolutely wrong option. Because what is the role of femtolasers in a cataract surgery? I hope you remember femtolasers are used to make cuts or incisions in the cataract surgery. Yes or no? So nuclear emulsification is no way a job of femtolaser. So the correct answer here is pseudo exfoliation can lead to subluxation in the cataract surgery. So let us go through all the options very quickly. This is another picture question where all of us can see that this is the trypan blue dye to stain the anterior capsule. It gives us a good visibility, good contrast. Okay, this is the one. Now, these are some viscoelastics. Again, this can be a question. What is the use of viscoelastics in cataract surgery? Okay, so they maintain the anterior chamber. They protect the corneal endothelium. Another very, very important question. They lubricate the injector and the IOL. It dilates the pupil as well. So why I'm telling you these things? Because viscoelastics have a very, very important role for the surgeon in cataract surgery. And probably they can also ask you. So this is a picture question on femtolasers, guys. Can you see site number 1, site number 2, and site number 3? These are the 3 jobs that femtolasers are doing. So wherever we require to make incision in a cataract surgery, it will be made by femtolaser. Okay. Now here, a very, very, very important topic. Guys, 2 years back in INICET, we have a similar question. Where do you see a target sign? So target sign is seeing multiple rings of that pseudo exfoliated material on the anterior capsule. So this is another accumulation of that pseudo exfoliated material. Now guys, whenever this pseudo exfoliated material goes towards the zonules, these zonules become very lax and they get torn. They are ruptured during the surgery. So when I'm operating, I'll see the lens is going down. Okay, lens subluxates during the surgery. So this is a very dangerous complication which can happen in pseudo exfoliation patients, and we really, really have a kind of heart attack during the surgery. So it shouldn't happen. Right, everyone? So this may be your picture question here. Now I'll go again with your IFS, and I want to tell you something more about this. So friends, whenever we are operating cataract surgery patient, with our male patients, we always take a history of tamsulosin. Okay, we always take a history of tamsulosin. So these are the drugs which are given for prostate, okay, prostatomegaly. Right. Whenever somebody has use of tamsulosin and he is using this during the surgery, there is a high chance of the iris getting progressively constricted. The pupil will become smaller when we start operating. So this creates a lot of problem for us. So we always say that the tamsulosin drug should be stopped at least 3 to 4 days prior to the cataract surgery. Okay. Otherwise, this is a good one. You have to use the drug, and after the cataract surgery is done, we'll say the patient that he can use tamsulosin. There is no contraindication after that. Okay. But please remember, we can have a question related to IFS in the next upcoming exam. Now, this is an easy one, guys. What should be the answer here? Which of the following features help differentiate papillitis from papilledema? Okay, so if you have learned neuro-ophthalmology, you should be able to recall that papillitis is nothing but what? It is an inflammation of papillitis, an inflammation of optic nerve. So obviously the patient has loss of vision in papillitis, but in papilledema, the vision is normal first. Okay, so visual status, yes. What about laterality of involvement? Papillitis usually has a unilateral loss of vision. Papilledema is almost always bilateral, right, everyone? What about magnitude of edema? So magnitude of edema, you know, papilledema, there is a gross disc edema. It is said that disc can enlarge even 8 times to its normal size. What about papillitis? There is always a minimal enlargement, minimal swelling of the disc. Okay. So I would say the best answer is all of the above, because all three of them differentiates papillitis from papilledema. What about treatment here? So the treatment of papilledema will be treat the cause, decrease the ICT, and hence the patient will get back everything. What about pupils again? So pupils are normal in papilledema and pupils will show RAPD in papillitis. Okay. So very quickly, a picture question on papilledema. As you can see, there is a very gross enlargement of the disc. We can't see any borders of the disc, and there's a lot of hemorrhage around the disc. So this picture is called as the angry sun appearance. What about the visual field here? There's no scotoma in the visual field, but we'll say enlarged blind spot. Okay. So if this is a normal blind spot, in papilledema, we'll see a very enlarged blind spot. Why? Because papilledema, there's a gross edema of the disc, so blind spot will also be enlarged. So this is what you should know. What about this papillitis? Please remember, in papillitis, only the optic disc is inflamed. Only the intraocular part is inflamed. So what will happen? You will have a very minimal edema of the disc, very minimal edema. And what is this picture? A very beautiful picture. Please remember, this is a picture of a macular star with a papillitis. So I will say this is a picture of neuroretinitis. Another expected question in your upcoming INICET exam. Because remember, this type of optic neuritis is not associated with multiple sclerosis. I hope you remember. It is not associated with multiple sclerosis. Neuroretinitis, when you see in patients, it is mostly due to a prolonged viral illness. Okay. Remember, this type of optic neuritis is not associated with multiple sclerosis. Yes, Dr. Anuj is absolutely right. You also have pattern lines in papilledema. Okay. Now, anyone, what is the answer here? If you have an old patient with hypertension, with atherosclerosis, and there is a sudden onset of field defect. So what is the quick diagnosis here? Anyone, if you can answer. If you have a superior field defect in perimetry. So I would say none of you could answer. So this is a condition which is called as AION. Okay. So remember AION also. Okay, they can ask you a question related to another field, because last year we had a question on enlarged blind spot in the visual field. Similarly, you can have a picture question on superior field defects in AION also. Okay. Now let's move to a question which is very, very commonly asked in our exam. Everyone know that we have asked you about VKC, because what are the hints here? We have a small child, there is a itching, there is a discharge during summer. So another clue, summers. Eyes are red and there is a ropey discharge. So this is also a clue. And you see some spots on the limbus. So what is correct about this eye condition? So first of all, can I say this is a condition which is called as VKC? Yes, this is VKC. Now, do you look for Herbert pits? Absolutely not. We have those small dots as Horner Tranta spots, isn't it? So we don't have those Herbert pits here, right? Now, cobblestone papillae are seen in all patients like him? No, because we also have limbal type of VKC. So in limbal type of VKC, we don't have cobblestone papillae. Please remember, cobblestone papilla are seen in children of VKC, but cobblestone papilla are there when you have papillary type of VKC. If you have a limbal type of VKC, you may not see cobblestone papillae. So I will say this is a picture of Horner Tranta spot, and this is mostly a limbal involvement. Okay, it is not papillary involvement. Now, a long-term loteprednol can be given. No, loteprednol, it's a low-dose steroid. How can I give a low-dose steroid for a long-term? No, we have so many ocular side effects, right? We can't give that. So what about the last option? This is the correct answer. So as elastin. So guys, as traditionally we have read that olopatadine is a drug of choice because it is a combination of mast cell stabilizers and antihistaminic agents. Similarly, azilastin is a new drug which is also a combination drug. So it is very much like olopatadine. So I would say this is another correct answer, or the drug of choice. So we can give long-term azilastin or olopatadine because they don't have really many side effects, but a long-term steroids, no guys, we can't give long-term steroids. So this will be the correct answer. Okay, so there are so many picture questions related to VKC also. We can have this ropey discharge. These are Denny Morgan folds which appears due to, you know, the repeatedly itching by the patient. And there is also a Maxwell-Loyal sign. Dr. Anuj, it is a combination drug. It is not only antihistaminic. Okay. So this is a limbal type of VKC. Again, we have here the pseudogerontoxone. Isn't it? This is a pseudogerontoxone. Right. So last year we had a question related to shield ulcer. Remember, these shield ulcer are like a shield, shape of a shield. They're always present in the superior half of the cornea. So this can be another picture question to you. Now, let's move on to the 8th question. So we have a 70-year-old male who comes with blurred vision since one day. On examination, his retina picture is given. What is least associated with this retinal disorder? So guys, first of all, what is the diagnosis here? Can you see this is a splash tomato appearance or a thunderstorm appearance? So can I say this is a picture of CRVO? So if this happens to be a CRVO, we expect a venous toxicity. We expect a cystoid macular edema as well. We can have a RAPD also, especially in ischemic variety. But what about primary optic atrophy? Okay, so I would say later on we can have a optic atrophy, but in condition like this where you have such a full-blown CRVO, this one will be the odd man out. This one will not happen so early. Okay, optic atrophy can happen, but not so early. So these three things can be seen. Now, friends, what I mean to say here is what I want to impress upon on this question is that RAPD can also be seen in CRVO, especially once you have ischemic type of CRVO. Okay, please remember this can be another question. Okay, so let's quickly go through the fundus picture here. This is characteristically a CRAO with a cherry red spot. You should know what is the reason of cherry red spot. That in fovea ganglion cell layer is completely absent. You should know these things. Okay. And we should also talk about the differential diagnosis of the cherry red spot. So I would say this is a very, very important slide for all of us. Remember, Gaucher's disease will be the last one in your list because Gaucher's disease can also have a cherry red spot. Okay, please remember, this is another important question which students keeps on asking us. So in one type of Gaucher's disease, we can have a cherry red spot. Okay, friends, but I will say this will be last in the list. All right. Now, we expect one question probably if it comes from CRAO or a cherry red spot or that fundus picture. Please remember, you should know how to differentiate Niemann-Pick's disease from Sandhoff disease and Tay-Sachs disease. Okay, so every question is important. You should know how the patient is presenting. All right, everyone, this is important for us. Now, the next question. So it says that there is a 15-year-old boy presented by parents with decrease in vision. They also report the child to have night blindness earlier. Okay, so a 15-year-old boy, night blindness. I'll straight away go with retinitis pigmentosa. Yes or no? Now, let us see what the question has further. The child has a severe malnourishment also in his early childhood. Probably they are talking about vitamin A deficiency also. Right? Now, such complaints are also there in one of the family members. So can I say there is also a family history? Yes. So my diagnosis is again going towards the retinitis pigmentosa. Now, retina shows everything normal except the thinning of the vessels. So what is your next for diagnosis? So first of all, guys, can I say this is retinitis pigmentosa sign pigmento type? You know, na sign pigmento. Characteristically in retinitis pigmentosa, we have a triad. What is that triad? BARP triad, bony spicules, thin attenuated vessels, and P stands for pale disc. Now, friends, if you characteristically see this triad, diagnosis is very easy. Diagnosis is very much clinical. But there are different variants of retinitis pigmentosa. And in some of them, we don't have these bony spicules. Bony spicules are absent. So if this bony spicule is absent, diagnosis clinical becomes very different, very difficult. In such a case, we need to take a help of ERG. So that's what I want to say, guys. There are some variations in retinitis pigmentosa also. So guys, I would say because this year we had one question from retinitis pigmentosa, they can ask you anything about retinitis pigmentosa. This question should be very, very, very much on your tips. Okay. So I'll quickly tell you, a young boy, 10, 12 years of age, having maybe a family history, because most cases are sporadic, but sometimes you can have a autosomal recessive, autosomal dominant, and even X-linked cases as well. So if you have these type of histories present and patient has a night blindness in early time, if you see characteristically the BARP triad, A, attenuated vessel, which is the most consistent finding. Even if you don't have bony spicules, but your vessels are thin, attenuated, then you must think about retinitis pigmentosa. Okay. I know there are so many variations. So if you have variations, then you can take the help of ERG. Now, what is ERG? Electroretinogram. Another expected question this year. I hope you know that this gives you mass retinal response. Okay. We check the electric potential generated at the level of retina under dark adapted conditions for 15 minutes. Then we again check the retinal potential generated in the bright light adapted condition. Okay, so we get mainly two waves, the A wave, which is a negative wave, and B wave, which is a positive wave. Okay, sometimes we may also see a C wave. This is another positive wave which is generated by the retinal pigment epithelium. Okay, sometimes we also get a C wave. Okay, now remember, these three waves normally look like that: A negative, B positive, and C another small positive wave. But if you have a flat ERG, or if you start seeing decrease in the amplitude of the waves, that means it is suggestive of problem in ERG. And with what problem? Some retinal dystrophies, retinal pigment atrophies, or any other mass retinal disorder will give you an abnormal ERG. Okay, so remember, this ERG can be another picture question. Now, with that, I would like to tell you that these patients of retinitis pigmentosa can have associations of these syndromes. Okay, Usher syndrome, that is the most important one, most common syndromic association. We may have Refsum's disease, Lawrence-Moon-Beadle syndrome, Bardet-Biedl syndrome, Friedreich's ataxia, A-beta lipoproteinemia, and even NAR. Okay, so these questions are very, very important for us. Now, guys, you must be knowing that there is no treatment for retinitis pigmentosa. We can't regenerate the photoreceptors back. But nowadays, there is a kind of electrode which we can put in the retina. It is said that these implants, the Argus 2 implants, they can restore the central vision. So this is new in retinitis pigmentosa. You can remember that as well. Okay. Now, another important expected question, guys, we can have one question from keratoconus because nowadays this is a very hot upcoming topic. So what can be associated with this patient except looking at this picture, I know that this sign is the Munson sign. Yes, everyone, I know this sign is Munson sign. Now, if I know this is Munson sign, I know this is, we are talking about keratoconus. Now, repeated change of prescription is definitely a feature. Thinning of cornea may be seen in the center. Distortion of corneal reflex is present in the center. But keratoconus is no way seen in middle age because keratoconus starts at around 15 to 18 years and it is aborted or it is completed by 30 years. There is no further progression. So in middle age, we can't have keratoconus. So remember, this is another very, very important question. Okay. Now, what is keratoconus? This is an ectasia where the cornea becomes thin in the center and it shows repeat change in curvature. Okay, after every few months, the patient has a different difficulty in vision because there is a change in the power of the spectacles. Okay, we characteristically see Munson sign. There are so many other signs also, like we have Rizzuti sign, we have oil droplet reflex, there is a scissoring reflex, etc. Okay, so once you know the question, we are talking about keratoconus, how to diagnose. So guys, again, another expected question. This is a picture of pentacam, which tells you thickness of the cornea and power of the cornea at various points. So this is the diagram. This is the colored picture where we have the curvatures of the cornea. This is the scan where we have thickness of the cornea. So green means normal. If somebody has green area, it means it is normal. Somebody who has a red areas in the center, these red areas in the center means that there is a thinning of the cornea. So thinning of the cornea is mostly suggestive of keratoconus here. All right. Now, how to treat? I know you know there are two picture questions. The first picture question, which has been there in our exams already, this is called as C3R. This is the treatment of choice for keratoconus. And there was one more picture question on intacs, ICRS, intracorneal ring segments, which are also known by the name of intacs. Okay, so we can have two picture questions here from keratoconus treatment. One on C3R, another one on intacs. Okay, so these are the treatment of choice here. Now, a very easy question I have kept here, but I want to tell you that limbus anatomy is also very important as an upcoming exam question. So they are asking you what is wrong about limbus. So it is a 1 to 2 millimeter wide zone as a junction of cornea and sclera. Can I say this is correct? Yes, limbus is like that. It has stem cells in the basal corneal epithelium. Yes, again, guys, this is a correct answer. We know that stem cells are present in the epithelium, but where in the epithelium? They are present in the basal corneal epithelium. Incision is made at limbus for cataract surgery. Yes, again, this is again a correct statement. But superior rectus is not closest to the limbus. So this will be the correct answer here. Because we know that when the muscles are attached on the sclera, they're coming from behind. When they're coming on the sclera, there is a distance of each recti from the limbus. This is around 5 mm. This is around 6 mm. This is around 7 mm. And this is around 8 mm. So it's like this. Can I say MR, medial rectus muscle, is the closest to the limbus and superior rectus rather is the farthest from the limbus. So this is important for us to know. Okay. Now going back to this diagram, you should know that this is the epithelium and these are the basal layer of the epithelium. So from that basal layer of epithelium, you will have the stem cells. Okay. Stem cells are present at the basal layer of the epithelium of the cornea. Okay. Please remember, this is another question. Now, what is this? So can I say this is a small little epithelial defect on the level of the cornea and it is stained green in color by fluorescein dye. So the moment you have an epithelial defect, you just need to patch the eye for a day and it will be healed on its own. Okay, the basics is that the corneal epithelium can regenerate. So that is why you just have to close the eye and patch the eye for one day, right, everyone? Now, guys, this is a very similar question which has been there in your exam last year in NEET PG. Okay, I have just modulated the question, little twisted the question. So let us see what it says. It says that there is a 70-year-old man who has a decrease in vision in right eye. There is also a history of systemic illness, hypertension, diabetes, hypercholesterolemia. Now there is a decrease in vision in right half of the field. Okay, right half of the field means this area, right? MRI shows infarction. So which is the most likely site of infarction? Anyone? What should be the correct answer here? So guys, can I say if the patient has a problem in the right field, can I say we call it the right homonymous hemianopia? If the patient has a right homonymous hemianopia, I would say the best to mark is the left-sided optic tract. Okay. A similar question was there in your exam last year. All right, everyone. Now, some more picture questions here from this. This is a picture of a bitemporal hemianopia, and I will say the site of lesion will be in the central part of chiasma, maybe a pituitary tumor, maybe a craniopharyngioma, right, everyone? Yes, B is the correct answer. Now, this is another way of asking you the question, where is the lesion? So can I say, instead of giving you black areas, I have given you areas which are seen areas. Now, can I say this is a left homonymous hemianopia? And if this is a left homonymous hemianopia, I would say the problem is on the right-sided optic tract. Okay, this is the correct answer, right-sided optic tract. Now here, what is the problem? The problem is that there is a visual cortex lesion because we have a macular sparing areas. So the problem is in the left visual cortex or the occipital cortex, you can say. Okay, this is characteristically a macular sparing homonymous hemianopia. Yes, a similar question was there in FMG exam too, right? Now, what is this? Who can tell me what is this? So I would say, guys, this is a junctional scotoma of trachor. What is junctional scotoma of trachor? Theoretically, they have asked you, now if you have a problem in the proximal part of left optic nerve, this shows the proper problem in the proximal part of left optic nerve. So the left visual field is gone. You have a central scotoma in the left visual field, and you also have a right supratemporal quadrantanopia. So this whole visual field defect is called as junctional scotoma of trachor. Okay. Remember, this may be another question, a picture question. Now, some question on glaucoma. So it was a very tricky one. Let us see if you can answer. So we have a 60-year-old female complaining of frequent headaches since 2 years. The vision is almost normal and there's an early nuclear cataract. Her pressures are slightly high. And there is a shallow anterior chamber in both the eyes. So what is the correct statement regarding her condition? Can anyone try answering here? What is the best answer? Anyone, if you can try. So friends, will you treat it? Yes, of course, we'll treat it. We don't have to wait and watch. Why? Because the patient is symptomatic and there is a little pressure high. And we also see there is a shallow anterior chamber. So friends, I would like to do a gonioscopy, and if there are narrow angles, I will do a laser treatment for the patient. Okay, there is no need to do a trabeculectomy here. There is no need to do a trabeculotomy also here. Okay, and we can't wait and watch here. We are talking about the shallow chamber glaucoma or the shallow anterior glaucoma. So Dr. Karthika, you're absolutely right. Okay, please remember, in angle closure glaucoma, even if the patient has a narrow angle, remember, if the patient is symptomatic, even if the pressure is in normal side, okay, but the patient is having frequent headaches or patient has pain in the eye, or sometimes the patient is having some symptoms, this is an indication of laser again. Okay, so iridotomy will be the treatment here. All right, please remember this question. Now friends, I hope the same question was there in NEET PG. This year they have given you a scenario that patient has gone to a movie theater in dark and there were emotions also. So the patient developed an angle closure glaucoma attack. But we are not talking here about the attack. We are talking about just a mild stage. Okay. Patient may not have a glaucoma, but she or he may have a primary angle closure. So even if the patient has a primary angle closure, in iridotomy has to be done. Okay, please remember, this may be an important question. So in an acute congestive angle closure glaucoma attack, how will you diagnose? You will say the cornea is hazy, pupils are mid-dilated, vertically oval, and pressure is very, very high. And this is a proper, very beautiful picture question also related to this. What is the first drug given? The first drug given is always mannitol. That has to be given in IV dosage. Glycerol can be given if the patient is non-diabetic. You can start 2 tablets of acetozolamide stat. Pilocarpine will be given to break the attack, to induce meiosis. And finally, we'll do peripheral iridotomy for both the eyes. Okay, so this is your flow chart to show you how to manage a acute congestive glaucoma attack. Okay, guys. So this is a picture question on laser iridotomy. The rationale is that we have to make a alternative channel of drainage of aqueous humor through this. Okay, this is how we do a peripheral iridotomy. Which lasers are we using? We are using ND-YAG laser. Okay, another picture question. Trabeculectomy will be done in only cases when the patient is not responding to iridotomy. Okay, we are not doing otherwise trabeculectomy in all the patients. Okay. Now, another very good question. So, guys, this is a little controversial question which came to last year in INICET. So I have just twisted little options because I want to make some concepts clear to you. Okay, please try to understand this question. So they are asking you what is true about open angle glaucoma. Okay, so do you think that isoptric contraction is a specific visual field defect? No, not at all. Though it is an early field defect, but it is not a specific visual field defect. So this option is out. Right, everyone? Now, for diagnosing open angle glaucoma in gonioscopy, best is to do direct gonioscopy in sitting position. Is it? First of all, remember, direct gonioscopy is not done in sitting position. We do a direct gonioscopy only when the patient is in lying down position. So this is out. Okay. All right, everyone. Rather, in our common day-to-day practice, we are using indirect gonioscopes, right? Like Zeiss gonio lens we are using mostly. Okay. So this is again a incorrect option. Now next. Next says that visual field defects are always associated with optic nerve head changes. So guys, I would say this is also an incorrect statement. Visual field defects generally they are matching with optic nerve head changes, but sometimes you can have optic nerve head changes, visual fields are normal, and sometimes visual field defects are present and optic nerve head changes are not present. So sometimes these things can also happen, right? By the way, I'm sure you know that visual field defects become apparent when almost 30 to 40% ganglion cell damage has already been there. All right, remember guys, this is a very, very important topic. Now this I would say is the best answer because this coverage is more commonly seen in normal tension glaucoma as compared to POAG. So I would like to show you a picture of glaucoma. Very important is this picture question where we have enlarged CDR ratio and this is a picture of a disc hemorrhage. What is the other name? We also call this Drans hemorrhages. Okay, Drans hemorrhages. So this can be seen in POAG, but this is more commonly seen in normal tension glaucoma. All right, guys, we can have more questions related to that. So what is this picture? What are we doing here? Can I say this is visual field analysis? And what is it? This is Humphrey's visual field analyzer. All right, another picture question. Now, so friends, something about superior oblique palsy. So right superior oblique palsy will lead to accept. Anyone, what is the correct answer? What should be the correct answer here? So I hope you all remember from the classes for superior oblique palsy, the fourth nerve palsy, we remember the term opposite. What is opposite here? If there is a problem related to right superior oblique palsy, then the head posture will be, first there is a chin depression, then there is a face turn to opposite side as an adaptation to avoid diplopia, and there is a head tilt to the opposite shoulder. Okay, these are the things which one should remember. So can I say right head tilt is absolutely out? Because for a right superior oblique palsy, the patient will adapt the left head tilt. This is the correct answer. Okay. Now remember here the patient has a left hypertropia. So she will have a posture like that. Right face turn, head tilt towards the right shoulder, and there's a slight chin depression, right? Something like your favorite Pushpa. Okay, please remember, this is the picture, the head posture to avoid the diplopia. Okay, guys, remember this can be a very, very important question. Now, Question number 16, what does it say? So it says that there's a young man of 30 years. He came with redness and watering, and there's a photophobia also. He took some medicines from a local chemist, and now he has got pain also since early morning. The vision is poor in the affected eye. His picture is shown here. What is the likely eye drop he has taken? Anyone? What is the answer? What should be the best answer here? Anyone? Angelica. Very, very good. Dr. Shweta, you're absolutely right. So what I want to say is that the patient probably when he came, he took medicines from a local chemist, probably he has given him D. What is D here? This D is dexamethasone. So it's a very potent steroid, and probably we are talking about a viral ulcer, a dendritic ulcer. Probably this patient has developed a dendritic ulcer, and if he has taken a steroid, what would have resulted? It has resulted into a big geographical ulcer. So this is what I want to say. Please remember, acyclovir is the treatment of choice, but steroids are absolutely contraindicated in cases of dendritic ulcer. Okay. So here I would like to tell you something more about dye. So what is the dye we are using here? This is the fluorescein dye. Okay, fluorescein dye, probably the patient had a dendritic ulcer at that time. But the moment he used steroids, it will all join each other and it will lead to a big ulcer that is called as a geographical ulcer. Okay, so the first stain here is fluorescein stain. This one was again green colored because there's a big geographical ulcer. Now, as you remember, this was a question in your INICET last year. So you should know everything about the dyes. Okay. We have discussed first of all the trypan blue dye. Then I'm telling you something about fluorescein dye, and probably the sequence now you use, that is fluorescein, lissamine, and rose bengal dye. Okay, please remember this is the correct sequence. Now you should also know some properties of fluorescein, that it is mainly used for dry eye checkup. It can be used for tear film breakup time. And you can check corneal epithelial defects, corneal ulcer, because it is going to stain the base of the ulcer green in color. Right, everyone? Remember, rose bengal dye, we are not using it as it gives pink color to the cornea and conjunctiva. But the main problem is that this is a very irritating dye. That's why we are not using this rose bengal dye. The next one is which we are using is a lissamine green dye in 1 to 2%. Remember, the same job is done by lissamine green dye and rose bengal dye. But the problem here is that though it is better tolerated by rose bengal dye, but the problem is that it does not stain the healthy cornea surface. This is it. Whereas rose bengal can stain the healthy cornea surface also. So you remember these differences in rose bengal dye and lissamine green dye. Okay, please remember these two changes. Now, the next question. So another very important topic, friends, I would like you to all understand this question, okay? Because some students got confused when a similar question was there in the exam. So we have an old man who had a painful red eye since one day. Cornea was hazy and there's a cataract also. Intraocular pressure is very high in the affected eye, and there is a deep anterior chamber also. So guys, first of all, please remember a patient of cataract cannot have a painful red eye. Okay, he can have a pain or redness in the eye when the pressure becomes high. So we can have this and this with the high pressure. Both of them can lead to a high pressure in a case of cataract. But what is the best answer here? It is a phacolytic glaucoma because the question mentions a deep AC. It has to be a phacomorphic glaucoma when the AC is shallow. Okay, that's what I want to say. Both of them can present very similar to each other. A patient can develop a phacomorphic, a patient can develop a phacolytic also. But if the chamber is deep, you will say it is a phacolytic glaucoma, because phacolytic glaucoma occurs in HMSC Morgagnian type. What happens in Morgagnian type? The problem is there are ruptures in the anterior capsule through which the lens proteins are leaking out. When lens proteins are leaking out, they are going to block the trabecular meshwork. When they block the trabecular meshwork, they raise the pressure. Okay, friends, remember this much. And what is this appearance? This is called as bag of milk appearance. Okay, bag of milk appearance, right, everyone? So now, What about the question number 18? So there is a 10-year-old boy presented with drooping of upper eyelid since birth. What is the least related to this eye condition? So friends, another expected question this year, this is called as a congenital ptosis. Okay, so I will be taking up little briefly about congenital ptosis. Please see a patient. So this is a child who has developed a drooping of upper eyelid since birth. Most common problem is that the LPS muscle is underdeveloped or it is poorly developed. Okay, poorly developed. Okay, now in most of the cases we will do a LPS resection surgery. Most of the cases, right, everyone? We have to cut the LPS muscle short and give the perfect correction. Now, how to diagnose this congenital ptosis? Guys, there are some very important diagnostic things. First of all, the head posture. Can you see there is a chin elevation, right? Because there is a ptosis, there is a chin elevation. Now, very, very important is that there is absent of lid crease, okay? You all know that there is a lid crease here. But in congenital ptosis, the lid crease is absent. Okay, lid crease is absent. And can you also see there is a lid lag? Another beautiful picture. Right eye is going down, but the left eye is not going down. So there is a characteristic lid lag also. Okay. Don't confuse this lid lag with the lid lag of thyroid. Okay. Remember. So let's try to solve out this question. What is least related? They are asking you. Okay. Absent lid crease. I've just told you. Lid lag can also be seen. LPS resection can be tried. But what about this statement? Option number C. This is absolutely out. It is not the mandibular division of fifth nerve that is misdirected to levator. Actually, this is seen with Marcus gun jaw winking phenomenon. Yes or no? We had a question on Marcus gun jaw winking phenomenon where when the child, somebody sips or someone, moves the jaw to the opposite side, the ptosis improves. Yes or no? The ptosis improves. So that one is a Marcus gun jaw winking phenomenon, right, everyone? Now, any condition where we are doing a sling surgery, So I would say sling surgery is done in only one condition when we have bilateral congenital severe ptosis with a very poor LPS action. Right, everyone? Very poor LPS action. So sling surgery can be done in such conditions. Okay, remember this question. So another picture where we have a Marcus gun jaw winking phenomenon. Guys, this was a PYT, PYQ. So you should remember what is the problem here. The patient moves the jaw to the opposite side and the levator muscle will get innervation because this is also supplied by the fifth nerve. So there is a improvement in ptosis like that. Okay. Yes, it can happen in chewing time also. Yes, chewing time also. Yes. Now, another expected question, another very, very important topic for us. So guys, you should be able to differentiate episcleritis from scleritis. So let us talk about it. So episcleritis is a superficial inflammation of the episclera, which is a very common condition, which is seen in young adults. It's a painless condition. Even if I don't treat, the patient will be fine, right? It's not associated with any systemic disease, right? Now, what about scleritis? It is a very uncommon condition. It is seen in older individuals, especially older females, and it has an association of long-standing rheumatoid arthritis. It's a very painful condition, sight-threatening condition because it's a deep inflammation of the sclera, right? Now, friends, we have to treat this patient. So, friends, please remember the differences. Now, can I try solving this question now? So what is false about episcleritis? So inflammation on Tenon's capsule, or we can say the subtenon space. Yes, so yes, superficial vascular plexus involved. Yes, I told you just now. Blanching is seen with phenylephrine. So guys, this is a PYT. We know that if we put a drop of phenylephrine, because it's a good vasoconstrictor, it is going to reduce all the redness and the patient will have a white eye. Now, ocular complications are not at all seen in episcleritis. Forget about that being more common in scleritis. Okay, so this is going to be the correct answer. Now, guys, we can have more questions on staphylomas. Please remember these 5 types of staphylomas. They can give you any question related to staphyloma. I hope you know this is a picture of anterior staphyloma where there is ectasia of cornea with the uvea behind. And here, this picture question is of ciliary staphyloma. Okay. Please remember, don't get confused between ciliary staphyloma. Okay. This is also a ciliary staphyloma. I would say don't get confused between ciliary staphyloma and scleromalacia perforans. Okay. Remember, scleromalacia perforans is what? It is a anterior scleritis, necrotizing type without inflammation. So patient will have history suggestive of scleritis. There is an old female having a long-standing history of rheumatoid arthritis, but there is no pain. There is no redness, okay? You will see flat areas in the iris. There is no protrusion. There is no swelling. There is no pain. There is no redness also, okay? So you should be able to differentiate any patient of scleritis, that is a very painful condition, how to differentiate it from episcleritis, how to differentiate it from staphyloma, and how to differentiate it from scleromalacia perforans. Okay, these 5 things, guys, you should be through. You should be knowing it. Now, another new question and expected question. So, guys, if they have started asking you about scleritis, episcleritis, staphylomas, and even scleromalacia perforans, they can one day ask you about posterior sclerotic also. So what is it? If you have that posterior scleral inflammation, right? You won't have a red eye, first of all. Okay. There may be a pain, there may be a tenderness, there may be a proptosis also, because the problem is behind. Okay. Patient will have a gradual onset of proptosis and there's a pain, tenderness in the eye. Once you see the retina, you may have these type of features, papilledema, maybe a exudative RD, or even folds in the choroid. Now, characteristically, please remember on ultrasound, we have a T sign. This is the T. Okay, this is the T. So where is the fluid collected? Theoretically, they have asked you. This is fluid collection in the subtenon space. Okay, subtenon space. Right, everyone? Now, the last question, another expected question this year, something about Fuchs heterochromia iridocyclitis. So guys, let's talk about it. I hope you know it is a atypical uveitis, right? Where the patient has a difference in the color of the iris. You have a mild, chronic, very low grade uveitis. Okay, this makes it atypical. There is no pain, there is no redness. There's a classical triad, we call it chick triad. What is chick? C stands for cataract. HI stands for heterochromia iridium. K stands for keratic precipitates, which are diffuse keratic precipitates. Please remember, this is one thing which makes it different from the typical uveitic cases, okay? Almost 50% of patients can have glaucoma also. Remember, we don't have any posterior sign, okay? We have a very beautiful sign once we do the cataract surgery. There is bleeding from the new vessels inside the iris, okay? So please remember, these may be the questions. Now, let's go and solve our question. So is there a mild loss of vision? Yes. Mild inflammation in eye? Yes, the inflammation is very, very mild. Cataract relates to decrease in vision. Yes, of course, this is the correct answer, but we don't have sectoral inferior KPs. I told you the KPs in Fuchs is diffuse. It's not inferior KPs as we see in the normal case of uveitis. Okay, friends? So this is a incorrect answer. Now, guys, I hope you understood something. I have taken up some very new questions, some new important expected topics that may be there in your INICET exam. Like we expect one question from squint examination, maybe one question from sclera, something related to cataract surgery, a new question they can give you maybe about lasers or something about retinitis pigmentosa related to ERG, syndromes association, atypical uveitis in the form of Posner-Schlossman syndrome, or even Fuchs heterochromia iridocyclitis. So remember, guys, I hope you are doing very, very well and you will be preparing very hard. So best of luck from my side and everyone and DocTutorials. So keep looking at the 2020 series. I hope you are enjoying and do your best. So thank you very much.